most common corneal disorder in the United States. The most frequent way that you diagnose keratoconus is by something called corneal topography. And this measures the surface of the eye. And what happens with keratoconus, for those of you that aren't familiar, it affects the cornea, which is the front part of the eye. The cornea becomes abnormally thin, and then it bulges outward. And you can identify that bulging outward by using the corneal topography, because it measures the surface of the eye. The keratoconus, we've been doing a lot of research here at UCI related to keratoconus. Myself, Dr. Brown, and Dr. Jester have looked at imaging and molecular biology. Drs. Uhas and Dr. Kurtz have been working on the laser, and Drs. Steinert and Farid and Gaster have been looking at the clinical aspects of keratoconus. So basically, I've already told you a lot of this. That when it was recognized, and I want to get out of everybody's way here. Is it better if I sit down where? Okay, all right. This is what I was talking about, the corneal topography. This measures the surface of the eye, and you see the area where it's red. That's an area where it's bulging out. And this is a very typical pattern for a keratoconus cornea. There are at least 8 different faculty members here at UCI that are doing work on keratoconus, different aspects of it. And what we found is that there are 3 major pathological features of keratoconus. The first feature is corneal thinning. The second feature is oxidative damage. And the third feature is anterior corneal instability. And we found that these all interact with each other. Now, it's since the 1960s, people have known that keratoconus is abnormally thin, the corneas are abnormally thin, and there's increased degradative enzyme activities related to keratoconus. And just as the enzyme activities go up, the normal inhibitors that block that activity goes down. So what happens in keratoconus is that you have elevated enzyme activity. Now, in a normal tissue, there's a normal cornea, there's collagen that's produced. And that's in a balance with these degradative enzymes. But with keratoconus, you have increased enzyme activity, and the collagen then is digested, and you get a thinner cornea. And you can see this. This is a schematic of a normal cornea. The outer surface, the blue cells, that's a cellular layer. It's called epithelium. But the majority of the cornea is actually collagen. And the normal cornea is about 500 to 550 microns thick. But if you have increased enzyme activity, it digests that collagen, and what happens is that you then have a much thinner cornea. The second feature of keratoconus is oxidative damage. Now, in a normal tissue, you have just the normal activities. You're out in the sun, you rub your eyes, you may have allergies, and these are just normal events. But anytime that happens, the tissue produces something called free radicals, or reactive oxygen species. But fortunately for all of our tissues, we have enzymes that can remove those compounds. And when that happens, you basically have a normal cell function. You don't have any damage. However, based on years of experiments, we know that in keratoconus, if those people are exposed to the exact same events, the normal sunlight, and perhaps their genetic components, you again have the reactive oxygen species produced. But the normal enzymes that are supposed to remove those reactive oxygen species do not work. So you have an elevation of the ROS. This can stimulate the more enzyme activity to occur, and it can cause abnormal cell function. And all of that leads to corneal thinning. Now, the third area is anterior corneal instability. And Dr. Jester will be showing you more of this when he shows you the confocal microscope today. Now, in a normal cornea, I showed you that picture with the epithelium, which is on the surface, and then the majority is the stroma. They're little tiny anchoring fibrils that attach from the anterior part through up to the epithelium, and that holds everything in place. And those are called anchoring fibrils. The other thing that normal corneas have is that the collagen is laid out in a very organized pattern, and they're interconnected to each other. And this just is, again, a schematic, and you can see the anchoring fibrils that help stabilize, and then these lamellae, or layers, in the stroma of collagen, and they're very organized. However, in keratoconus, they lack these anchoring fibrils. They have many fewer anchoring fibrils. And the lamellae, or layers, are not evenly distributed and not organized. So as a result, there's a slippage that occurs, and again, that adds to instability. Because the function of the lamellae and the anchoring fibrils is to maintain corneal shape. If you lose the lamellae or the fibrils, you can get slippage, stretching, and warpage, and this creates an unstable matrix. So, in my view, here's the keratoconus. Here you have increased activity, you have oxidative damage, and you have substrate instability. Now, the standard measurement, the standard treatment for keratoconus, if it's very mild, a keratoconus patient might use spectacles. If it becomes a little more severe, they might use contact lenses. And it's only 10 to 20% of keratoconus patients that eventually require a corneal transplantation. But there are new developments in treatment. One of them is called Intacs, which are polymethyl methacrylate segments that are actually placed within the stroma. And the second is collagen corneal cross-linking, which I'll talk about in more detail. The Intacs are these methyl methacrylate segments that are placed within the stroma, and the function of them is when the keratoconus, it bulges outward, and by placing the segments at the base of the cone, it sort of stretches out the cornea and it flattens the cornea. Now, in terms of the cross-linking, this is a very new, exciting area. And the procedure is, with a cornea, you remove the outer surface, you have a small drop called riboflavin, you put the drop on the eye, and as you're putting the drop on the eye, you expose it to UVA light, which is a very, very short wavelength of light. And this just shows that schematically that you place the drops, you expose it with the laser, and it will cross-link the collagen. What is the effect of increasing the cross-linking? If you look at this little diagram of number 2, that's a pig cornea, and when you take the cornea, it's not very rigid, so gravity will just make it bend down. But if you've cross-linked it, you've stabilized it, now it's much more rigid and it holds things in place. Now, there are most of the in-depth studies, the longer studies on collagen cross-linking have been done in Europe, and there are some studies that have been reported out to 5 years. And they've shown that with the collagen cross-linking, you can stabilize the cornea so there's no progression of steepening. The visual acuity in those patients are slightly improved, as opposed to the other eye, which is not treated, which often shows progression of the steepening. Now, in terms of the status of that procedure in the United States, their initial clinical trials are being collected by the FDA, and there are a number of sites in the United States that are offering cross-linking under investigator-sponsored clinical studies. And here at UCI, Dr. Gaster is conducting a study, and also if you go to the National Keratoconus Foundation, it will list some of the other studies. Briefly, I just want to say, for people that are not having surgery, there are things you can do for keratoconus. We know that sunlight can increase the free radicals, so use your contacts of UV protection in your contacts or glasses. Also, it's critical that the contact lenses are fit properly, because if they're not fit properly, it can cause inflammatory cytokines and increase the free radical formation. And then also, we want to keep the keratoconus patient's eyes as comfortable as possible. So you can use preservative-free artificial tears. And if a person has allergies, they should be using anti-allergy medications or non-steroidal anti-inflammatories to help that. And then in terms of the antioxidant component, just a good diet, oxidant supplements, and a good diet with high levels of antioxidants, which are the green leafy vegetables, fish, and vegetables with colors. And much of this work has been done with support from the Discovery Eye Foundation, and we really couldn't have done it without them. So thank you very much. And I'll okay. I have time for a few questions if there are any. Question?
I have keratoconus and I actually have intacs. Just as far as not just me, but the future, with intacs, have they done any studies with the cross the riboflavin?
There are some people that are doing studies where they put both the intacs in, which would then flatten out the cornea, and then they use the cross-linking. The cross-linking doesn't really reverse the progression, reverse the steepening, but it will stop it from progressing. And that is the main value of the cross-linking. And that's why oftentimes people, when they're talking about cross-linking, they suggest doing it when the keratoconus is not very severe, because you don't want to have it just progressing and getting more and more steep.
Just for your own knowledge too, because I'm keratoconic. When I was a kid, I noticed this, that whenever I would be in the water in the pool, I would always have to rub my eyes. That was a genetic thing that I noticed. It wasn't something that I had to do. It was just a very sensitive eye.
Yes.
And as I grew up, I was like looking at my friends at the beach and the water, and nobody ever did that. And as I got older, my teens, my vision started getting worse. It's something that's...
People have felt that active eye rubbing in keratoconus patients may play a role. And the reason is with the eye rubbing, with the discomfort, we don't know if it's the chicken or the egg. If your eyes are uncomfortable, therefore you rub it. But in any case, once you rub it, once your eyes are uncomfortable, you stimulate pro-inflammatory factors, and those can play a role in keratoconus. So we always recommend that keratoconus patients not vigorously rub their eyes, which is hard sometimes.
Interesting. I did a lot of swimming when I was a teenager in school and everything, and mine seemed to develop when I was in my mid-20s. So.
Yeah, and that's a very
and I always remember the irritation of the eyes all the time.
Yes, and that's very, very common in keratoconus patients.
Do any of you who have keratoconus had keratoconus in the family? Anybody else besides you? The ones in my family. Because it is genetic, and we don't know exactly what Dr. Kenney has done a lot of work on the genetics of keratoconus, and unfortunately doesn't have time to tell you about that.
He says it skips a generation. Do you find that in your knowledge?
No, not necessarily. No. Do you have a question?
Yeah, my son has it quite bad, and he has to be on the computer all the time for his job, and he's just really struggling with his glasses. He can hardly see with them; they're so big, and the lenses are not doing him any good. And he's really so distraught over it. He said the only thing they could do is do a corneal transplant was too dangerous. So I don't know.
The question is, her son has keratoconus, has to be on the computer a lot. The glasses don't seem to help. It's very, very frustrating, and his eyes are very uncomfortable. And they've told him that the only thing he can do is a corneal transplant. And in the past that may have been true, but these new techniques that are coming out, there definitely can be potentially other options. And there are people that you put in intacs, which would flatten the cornea. It's a much less invasive procedure than a corneal transplant, and it doesn't prevent a person from getting a corneal transplant later.
Does it? Because when you do this, would it help? I mean, he's in a business, he has to be on it, and it's got hit hard by the recession, and so he's really struggling trying to keep the family and the house and the whole thing. And he feels he can't not be on that computer all the time. Is that a hindrance to this?
Computer affect Casey?
Is that the question? Does the computer, being on the
Yeah,
computer affect
yeah.
Casey? No, not,
No.
there are people that live in front of the computer and they never develop keratoconus. So just being on the computer by itself is not going to cause keratoconus.